The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. Dr. Jeremy Kendrick has been very kind this month in indulging me and letting me talk about what I'm referring to as the psychiatry grab bag this month. Talking about things that I've been doing this for a couple of decades now, and some of the situations that I think are just really, really hard to navigate. Jeremy, welcome back.
Thank you, sir. It's always great to be here. I appreciate the invitation.
And we will include the information about the call-up line in the show notes and take a minute again at the end of this episode to chat a little bit about it. Have you developed any disclosures in the meantime?
No disclosures for you yet. I'm working on my billion-dollar idea, but haven't quite gotten there.
Attaboy. This week, I wanted to talk about one of the really challenging topics, and that's the angry adolescent who shows up. It's a very difficult situation. It turns out these are often kids that I've known since they were born, but things have just kind of become much more difficult in every setting. So sometimes people come in and say, what do we do about our angry adolescent? And first of all, what in your world, what does anger represent?
Yeah, that is a great question. That's a very difficult question to answer with a specific kind of right answer, because I think it really does depend on the situation and on the patient. What I will say is, for me, the important thing is to recognize that anger is, in most cases, in and of itself, a symptom. It can be a symptom of normal development, and we can talk about that, but it can also be a symptom of a lot of other types of things that warrant a closer look. I think it is a flag that we absolutely should be paying attention to. I had a mentor one time that said that anger is the smoke. Our job is to find the fire, to understand where it's coming from.
Yeah. And it's interesting because I think we sometimes see there's anger at different stages of development, and the implications of an angry 18-month-old or an angry 4-year-old are different than an angry adolescent.
100%. Yeah. You can even start by saying, what is the differential of anger at all of these different stages? And developmental appropriateness waxes and wanes throughout development as far as a kind of a normal category. But I do think that the one thing that uniformly ties kind of concerning anger together really has to do with those factors that define how it's impacting function and the frequency of that, how long it's lasting. Is it dangerous? Is it impairing in other aspects? And so I think identifying the emotion in the context of the developmental stage your patient's at is your best first step to understand kind of your starting place, but not necessarily stopping there, especially if it feels out of proportion to what you're seeing in same age peers or siblings.
What sort of things do you want to think about when somebody, especially somebody who may not have been an angry person in the past, when they come in and they're just kind of persistently angry?
Yeah. For me, again, I think the acuity is absolutely a good clue to be looking into. I mean, if this is a kid who is kind of entering those difficult years and it's this gradual brewing kind of emotional dysregulation that becomes this kind of chronic angry state, but it's not impairing their function. It's not getting them in trouble at school. It's not getting in the way of all of their relationships. It's not happening in all of the settings that they're engaged with. It's a little easier to be less concerned and chalk it up more to kind of some of those stressors of development. But it's when I'm hearing about an acute change, this is something that happened over the course of a week or two, there's a real acute change in emotions. And when it really does take on that flavor of becoming universally affecting of relationships. It's not just affecting the relationship with the parents, but it's affecting the relationship with their peers at school, with their siblings. That is coming across, and it's cutting across all of those social strata that adolescents are navigating. And the frequency of the outbursts, how long they last, those are also other really important kind of characteristics to look at. And I think it's putting all of those pieces together where you start to say, Is this something I really need to be looking at an underlying differential diagnosis for other specific mental health categories that I need to be assessing versus I do think this is more of a developmentally appropriate type of presentation. And I think that is the crux of irritability and anger in adolescence, is understanding the difference between those two categories.
What can you tell me about disruptive mood dysregulation disorder? That's something I don't know much about.
Yeah, really, disruptive mood dysregulation disorder, in its title, it is mood dysregulation. So these are outbursts. These are the inability of adolescents to kind of manage that affective presentation, and it causes disruption. This is not just a kid who, tosses their hands up because they're frustrated they got to take the garbage out. These are kids that become disruptive with that dysregulation. And that can happen in the potential risk of the outburst. That can happen with, again, the frequency of the outburst, how dangerous it might be. But these are kids that have these episodic outbursts that can feel very, to use the words that we would use, can feel very manic. And I think these are kids that maybe historically, before this diagnostic category had been kind of considered, would have been potentially labeled as having like a bipolar disorder. The idea that these kids can have these periods of relative stability, but then out of nowhere, the Dr. Jekyll, Mr. Hyde, kind of these disruptive outbursts are the defining criteria, but they're not happening in a chronicity over time that would define a manic episode. And so it's really these episodic, severe, recurrent outbursts. And those are the types of kids that you want to think about with disruptive mood dysregulation, as opposed to something like a manic episode.
And do people with disruptive mood dysregulation respond to therapy? What's the usual approach there?
Absolutely. I think part of disruptive mood is understanding the factors that predispose people to get into those situations. So a lot of times part of the therapeutic approach here is looking at the outburst and the factors that led up to it. And a lot of times patients are able to understand patterns that they can work on accommodating moving forward. It really does have to do with this idea of understanding how those thoughts and those feelings lead to behaviors, and understanding that you can have some control to disrupt that pattern early before it leads to the actual presentation of the episode. And so cognitive behavioral therapy, surprise, ends up being a very important cornerstone of understanding the relationships between those thoughts, feelings, and then the inevitable behavior of the outburst, and how you can disrupt that cycle.
It strikes me that the resistance to therapy in this group of patients is frequently, I'm summarizing the answer is, if everyone in the world weren't so stupid, I wouldn't have to be angry.
It is true. And that's where you get this overlap. Being a grumpy, irritable adolescent is not mutually exclusive of having some of these more kind of diagnostic type of pictures. And when you get the overlap of the two, it can be a little tricky, because sometimes these kids are just kind of normal grumpy adolescents,
Mhm.
and other times they are causing real risk to themselves or others. And in their mind, it's very hard to understand the difference between the two situations. It's just, I wouldn't have thrown that chair if you wouldn't have been so annoying and asking me to take the trash out.
Right, right. I think one of the important things is that in many instances, angry adolescents, the key there is that they're working through some difficult changes in their lives, and a certain amount of, if not indulgence, but at least a certain amount of patience and understanding, saying, yeah, it's being an adolescent can be challenging.
Yeah, and I think when adolescents can experience some of that empathy and validation about the experience they're going through, for your quote unquote run of the mill, irritated, angry adolescent that is just dealing with the developmental stages that are involved, that really rough pathway that we
Yeah.
all walk through that adolescent phase, those kids respond very well to just some good, calm validation, because they're very used to being told, why are you so grumpy? You're so grumpy all the time. It becomes this identity. Whereas to sit down and really try to meet them where they're at in their adolescent experience, I think can be very powerful. That is not sufficient for patients that are showing these angry outbursts and things
Yeah.
because of an underlying
Yeah.
issue. And I think that's where identifying those two different types of patients becomes really important, because there absolutely are some other really important things to be looking for in the patients that may just presenting with anger.
Let's talk about a few of those. What about the neurodevelopmental sorts of things? When should I think about autism? When should I think about learning disabilities and language issues?
Yeah. And I think that's where pediatricians shine. I mean, I think when you're pairing this with a developmental history that starts to raise some concern in those areas, looking at their social connections, looking, at their developmental milestones, looking at all these other factors that can kind of help you understand the irritability and the outbursts in a different context. There is definitely a different quality to, a moderately affected autistic child, the outburst you see from them from the outburst of a toddler who's frustrated about being told to eat their vegetables. There's a quality to it. And I think you only have to spend a certain amount of time with some of these neurodevelopmental kids that it's very clear that there is something driving that's above and beyond just irritability or a behavioral outburst, that there really is what ends up being in a lot of these cases kind of a physiologic mechanism that's driving that. And that's where you start talking about, is this a situation where medication becomes something we should be looking into, as opposed to the cornerstone for these types of kids, which is going to be behavioral interventions.
Going back to the basics, I think one thing that gets overlooked in adolescence a lot is sleep. Do you find that in your practice that sleep makes a big difference in people's responses to what you're trying to do?
The biggest difference, and I oftentimes will tell patients as I'm talking to them, number one, two, and three on my differential diagnosis is sleep hygiene. It is very hard to really have a sophisticated diagnostic strategy for any of these other types of conditions if sleep is disrupted, which is hard because disruptive sleep is oftentimes a big part of a lot of these different diagnostic categories. But if this is a kid who can engage in some sleep hygiene skills and at least get to the point where they're getting sufficient enough sleep to be restorative, persistent anger beyond that is definitely a much different picture than the kids who do so much better if they've had a good night's sleep.
Any other things you think are especially important in getting a history on these kids?
Yeah, I mean, I think with your adolescents, there's some categories you really want to make sure that you cover. One of those is substance use. I think a lot of irritability can be the result of substances. And a lot of these kids may be using very discreetly and infrequently, but it's still sufficient enough to really cause some pretty significant dysregulation in their moods. So substance abuse, that's a real high priority to look at. I think the other one that I think we've gotten much better at talking to our patients about is trauma. And trauma histories are prevalent in adolescence, as far as that's really when they have the wherewithal to understand the weight of this and it really starts to manifest itself. Of course, the same can be said for younger kids who really don't have the wherewithal to
Right.
understand, and it's just an externalizing symptom at that point. So I think trauma at any age, these irritability, anger outbursts, externalizing behaviors are major red flag. And so I think screening for trauma is really important. ADHD, obviously, a very common, we think so much about inattention and we think so much about hyperactivity that a lot of times we forget that one of the core presentations for a lot of these kids really is emotional irritability. And that dysregulation can be a core component of ADHD that you see improve with appropriate treatment. But the treatment for ADHD looks very different from the treatment of disruptive mood dysregulation disorder or other affective conditions. And that's why understanding the core cause becomes that much more important, because the treatments are going to look very different, but lead you to a common outcome of improving that irritability.
Anything on the physical exam that you'd be looking for?
Yeah, I mean, I think you're always going to want to be looking for your classic signs of any underlying sign of distress, whether that's self-harm, cutting, trauma, those types of things. I mean, I do think that it's important from a medical standpoint to be thinking about other types of conditions, thyroid conditions, iron deficiencies. There are absolutely medical things that can get in the mix here that can disrupt sleep, or even without sleep disruption, lead to baseline irritability. So looking into all of those types of things on your physical exam and your lab workup are important. If there is a history of endocrine or metabolic things in the family, paying attention there, those conditions absolutely can lead to mood fluctuations. Understanding in the physical exam as far as the history, looking at onset, seeing if there are modifying factors that seem to help mood in those situations, I think can be a really important piece. I think the most important aspect that a pediatrician plays in all of this is what you were talking about earlier, and that is these families. You've followed these kids, you've seen them over time.
Yeah. Yeah.
And so when things change, I think you are uniquely positioned to be able to understand that change in a way that somebody seeing the patient in the emergency department for a single visit may not be.
Is there a simple way to teach de-escalation?
Yeah, I mean, I think for parents, the first step is helping them be very aware of how they themselves present and react to their kids' irritability. And I'm very fond of saying I am a much better child adolescent psychiatrist than I am a parent. And the fact of the matter
Absolutely.
is,
No, I
yeah,
get that 100%. And I tell parents all the time, if you were an AI robot, you would probably do this differently, but you have feelings of your own.
100%. And the stakes are high when they're your kids. You're worried about them,
Right.
and so that dynamic that develops, but recognizing just how much of a stumbling block that can be in the interaction. And these kids will play off of your reaction. And so an irritable outburst from a teenager towards a parent that's going to mimic that and raise their own voice and be like, you think you're irritable, I'll show you irritable. And that
Hmm.
you get that
Yeah.
escalation. De-escalation is the exact opposite. It's like the feeling of wanting to raise your voice. It's being very clear and conscientious about lowering the tone of your voice, slowing, using fewer words as opposed to more. Physical space is so important. A lot of times we as parents don't recognize how intimidating we can be with our size and specifically proximity. Giving attention to the physical space that you're in. Removing the audience, I think that's another real important for de-escalation. If this is a whole family gathering and this is happening, that's not the time to be addressing this irritability. I think that's where trying to remove you and your child to a situation where you have less variables to have to worry about kind of contributing to the situation is really important. I really do feel that once you get to that state of being calm, that's when you can get into the problem solving. That's when you can start talking about triggers, trying to process it, talking about limits and those types of things. During the escalated phases, you're just not going to have success. And it's just going to set up a pattern that will just reinforce itself every time. So I do think de-escalation is so much more about parents understanding how to de-escalate themselves first, and the rest usually follows suit.
It seems to me when I talk to parents of little kids, one of the points I always try to make is that the best behavioral reinforcement is reinforcing positive behavior, and that it's so important that a child recognizes that you're on their side. So finding a time outside the moment when you talk about,
Mhm.
look, when this happens, it makes us both sad. What are some other things we can do? And then trying to game the system so that in a situation that you set them up to succeed and say, look how well you just navigated that. I think that's a harder thing to do with adolescents.
Yeah, because they become almost as savvy as we are in the
Yeah,
behavioral, just as we're understanding the buttons that we need to twist to kind of de-escalate, they are very aware of the things that will
yeah.
ramp us up. And again, I think that is a dynamic that you have to be aware of. That said, even the most jaded adolescent I've worked with, I think you can find a time when the classic phrase, catch them doing right, catch them doing the right behavior and reinforcing that. I don't think there's any human being of any age that can be resistant to positive reinforcement for too long. And so I think that the more we as parents can try to back away from our need to label all of the things that are broken and need to change and start on the other side and focus on like what's going right, how can I reinforce that, and have that adolescent really start understanding that the attention is coming from them doing well as opposed to vice versa. Basic behavioral stuff, but like I said, it's so much easier for me to teach than for me to put in practice as a parent. So I think it's helpful reminders to us all as we're dealing with our adolescents.
It seems like in some ways that some version of meta motivational interviewing is what we're looking for here. Not just that we can do motivational interviewing with both the adolescent and the parent. What are some things that you could envision doing? But to some extent, giving them tools to be able to work with each other about what would be something that I could do, what's something that you would be willing to do, and figuring out how to reinforce compromise.
Yeah, that to me is one of the key principles of motivational interviewing is that it's flipping it on its head and it's saying, what are the things that you can do to introduce that cognitive dissonance of the fact that things are not as bad as they appear. They're actually shifting the mindset to saying like, oh, maybe things are better than I think. And it's not as big of a jump for us to have improvement by identifying those areas that we're already halfway there. And it's going to be a pretty easy win for us to improve those types of things. And I think motivational interviewing becomes a really important strategy in dealing with adolescents, 100%.
From a psychiatrist's point of view, which of these patients need referral both urgently and less urgently?
Yeah. I think at the point that you've identified, we talk about that smoke and fire, at the point that in that investigation, you do see that there's a patient that may be dealing with some really intense trauma that's going to require some more skilled assistance. That's where referral for therapies become really important. At the point that it's a particularly difficult neurodevelopmental case where you may need medication management. But ultimately, I think the thing that defines that is safety. And it really is at the point that despite all of the things we've talked about as far as ways to intervene, that safety cannot be secured because of the intensity here. That's where I think bringing in some additional help, whether that's a referral or just call up the telepsychiatry line and,
Sure.
and talking it over. I mean, I think the other piece of that is diagnostic uncertainty. If you've looked for the fire, and you're like, I don't know, I'm seeing some glowing embers all over the place here. Like, I'd love to talk this through. I think that's another situation where having referral or psychiatric teleconsultation can be really helpful.
I think one of the things, and as I mentioned at the first, we're going to circle around here to the call-up line. One of the things that I have found most useful of all is when I'm just kind of not exactly sure where to go from here, and being able to talk through something often get a lot more clarity about what I have already learned, as well as what I still need to learn about this case.
Yeah, I will say, and I do think that there is overwhelming value in these longitudinal relationships we have with families in primary care. I also do think that there is some value of running this case by somebody who really doesn't know much at all about the case other than the core symptomatic presentation of doing, because you may not be aware of some of the biases you're thinking about, having known the family and everything. And yeah, there's oftentimes where we'll bring something up and the pediatrician will be like, oh, weird, I never really thought about that. Like, that's interesting. That's a good thought. And so I do think that there's value in just having kind of an objective third party that can dip their toes in the case and look at it from different angles.
Absolutely. And hats off to you guys for doing a good job of it. And frankly, hats off to the state of Utah for funding this on an ongoing basis and recognizing this makes a real difference in taking good care of kids.
I've been so grateful for our friends in the legislature who have advocated so fiercely for kids in this state, and they've put their money where their mouth is. Yeah, I too am so grateful to be in a state that really values the mental health of their kids so highly.
Yeah, terrific. All right, Jeremy, thanks so much for indulging me this month. I feel a lot smarter than I did at the first of the month. I got a long way to go, but it's been very helpful. For those of you who have questions, please send your questions to questions@vcurb.com. I'm sure there are a lot of related things that we ought to be talking about, and we're happy to address that next week. In the meantime, thank you to our listeners for listening. We appreciate the ongoing support. Tell your friends and neighbors about us. Like and subscribe because I'm a needy guy. Thanks to Elisa Stoddard for making this sound like a podcast. And thanks to Janice for listening. We'll see you next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Paul Wirkus, who composed the theme music. See you next time.